Hello, Dr. Ammar here again, and in this video lesson we will talk about clinical vignettes regarding vertebral diseases. If you have any question, you can email me here at ammar@goodrational.com or comment your question down below. Here are the 8 cases we will talk about. First, Spina Bifida, Vertebroplasty, Scoliosis, Kyphosis, Lordosis, variation in vertebral number, vertebral cancer, and Osteoporosis. First, Spina Bifida. Spina Bifida is a developmental disorder in which the posterior arches fail to fuse, resulting in an open vertebral canal. Here are the types of Spina Bifida. First, we have Spina Bifida occulta, and we have meningocele or meningomyelocele. In Spina Bifida occulta, there is an opening of the vertebral canal, but without outpouching of the meninges. But in the case of meningocele, there is opening in the vertebral canal with outpouching of the meninges, and also in the meningomyelocele. Now, if the outpouching is limited to the meninges and the cerebrospinal fluid, it is meningocele. But if it is also include the meninges, the CSF, and also the spinal nerves or cord, it is called meningomyelocele. Now, in these cases, it is the severe form. However, the Spina Bifida is the commonest and usually asymptomatic. Now, in these cases, meningocele and meningomyelocele, it usually results in neurological deficits depending on the location with which they are associated. For example, if it is in the lumbosacral area, the patient might have problems in walking and problems in bladder function, so and so forth, depending on the location with which they are associated. But in the case of Spina Bifida, the patient is usually asymptomatic and usually diagnosed as an incidental finding. But during examination, you may find a tuft of hair over the spinous processes. Then we have vertebroplasty. In vertebroplasty, it is a technique in which we can fill the vertebral body with bone cement. Now, in what cases we want to fill the vertebral body with bone cement? Let's see. Here are the indications in which we use vertebroplasty. Vertebral body collapse, insufficiency fractures, osteoporotic wedge fractures, it is the most common, and vertebroplasty is mostly performed for patients with osteoporotic wedge fractures. Aggressive hemangioma, vertebral multiple myeloma, and vertebral metastasis. Now, in case of osteoporotic wedge fractures who undergo vertebroplasty, they have improved outcome and early mobilization. Now, let's see how it is performed. First, we put the patient under sedation or light general anesthetic. Then, using an X-ray guidance, we identify the pedicles. Here is using an AP view and lateral view. Here is the pedicle in the lateral view, and here is the pedicle on the AP view. Then, we mark the area to make an incision. We insert the trocar, metal cannula or the trocar, insert it, and anchor it on the bone. Just as we feel resistance, we anchor it on the bone and get an X-ray. Here's the bone, here is an AP view, here is the bevel of the trocar or the metal cannula, just anchored on the pedicle, and here is on the lateral view. We keep inserting. It should be kept away from the medial border of the pedicle to avoid injury of the vertebral canal or vertebral spinal cord or nerves. Here's a lateral view. Keep inserting the balloon, then we blow up the balloon to make a space in the osteoporotic vertebral body. Make a space. This space we want to fill the bone cement. We start inserting bone cement here, as you can see, and then we fill the vertebral body with bone cement. As you can notice, we fill the body with bone cement in the anterior two-thirds. Next, we have scoliosis. Scoliosis is abnormal lateral curvature of the spinal column with rotational element of one vertebra upon another. Now, there are multiple types of scoliosis. We have the idiopathic, it is the most common. Idiopathic scoliosis is the most common and never occurs at birth. Rather, it might occur at infantile stage or juvenile, but mostly adolescent. Next, we have congenital, which occurs at birth, neuropathic problems in central or peripheral nerves, muscular problems in the muscles. Most commonly, it is a rare group, but most commonly due to muscular dystrophy. Then we have other causes like bone tumors, mycoscoliosis, localized disc protrusions, mycoscoliosis. Let's see some pictures. Here's an X-ray of a neonate with congenital scoliosis. As you can see, congenital scoliosis is mostly associated with other abnormalities like chest wall abnormalities, genitourinary, as you can see here, or might have heart disease. So these patients must be evaluated carefully by many specialists. Then we have neuropathic scoliosis. The neuropathic, we've said, it is due to central or peripheral nerve problems. Now, in this patient have cerebral palsy. As you can see here, scoliosis with cerebral palsy, but it might be caused by peripheral or other nerve diseases like polio. Then we have muscular. It is rare group, but most commonly caused by Duchenne muscular dystrophy. In this disease, we have scoliosis, as you can see, and this is diagnosed by muscle biopsy. We need to take a muscle biopsy in order to diagnose muscular dystrophy. Lastly, the most common type, idiopathic scoliosis. As you can see, here is an adolescent, which most commonly, the age group most commonly affected by adolescents. Here is the scoliosis, but there is something you should notice, that the vertebral bodies and the posterior elements are normal, but there is scoliosis. So it is idiopathic. There is no known cause, unknown cause, idiopathic scoliosis. There is scoliosis, but there is no known cause, no organic cause. There is scoliosis. Your vertebral body normal, posterior elements are normal. Then we have kyphosis. It's an abnormal curvature of the thoracic vertebrae, producing a hunchback appearance, hunchback deformity. As you can see here, hunchback deformity, like mountains, mountain. This condition occurs in certain disease states, but the most dramatic of which is secondary to tuberculosis infection of thoracic vertebral body. Let's see some pictures. Here is a tuberculosis infection of vertebral body of thoracic vertebrae. Now, as you can see, the affected vertebral body is angulated at the site of the lesion. It is angulated at the site of the lesion, causing a deformity that is called gibbous deformity. Gibbous deformity. This is an extreme case of gibbous deformity. It is due to tuberculosis. Now, gibbous deformity was prevalent before the use of anti-tuberculosis medication. Here's two cases of gibbous deformity or kyphosis. Next, we have lordosis, increased curvatures of the lumbar or cervical concavity backwards. Now, it is abnormal, causing deformity that's called sway back deformity, sway back deformity, sway back deformity in the lumbar or cervical regions. Let's see some cases of variable vertebral numbers. First, we have fusion of cervicals. As you know, the normal cervicals are 7 in number. However, in some cases, they might be fused, like in Klippel-Feil syndrome. Klippel-Feil syndrome. In Klippel-Feil syndrome, the cervical 1 and cervical 2 are fused, or cervical 5 and 6 are fused. So there is fusion of cervical vertebrae, decreasing their number. Here's another picture of fused cervical vertebrae. In Klippel-Feil syndrome, not only the cervical vertebrae are fused, but also there is high riding scapulae, what is called as Springel's shoulder, as well as cardiac abnormalities. Next, we have sacralization of the fifth lumbar vertebrae. It is one of the commonest abnormalities in lumbar vertebrae. There is, as you can see, partial fusion of the fifth lumbar vertebrae with the sacrum. It's called sacralization because the fifth lumbar acts as a sacrum. As you can see how broad it is. It is partially fused with the sacrum, called sacralization of the fifth lumbar vertebrae. We also have lumbarization of the first sacral vertebra. In which there is partial separation of the first sacral vertebra from the sacrum to the lumbar region. So it's called lumbarization of the first sacral vertebra. Finally, we have hemivertebra. Hemivertebra occurs when vertebra develops only on one side. As you can see here, multiple vertebrae in this region develops only in one side. Here's vertebra develops on one side, on one side, on one side, keeping this other side deficient. Now let's talk about vertebrae and cancer. Now, vertebrae are common site for metastatic disease, secondary spread of cancer cells. Now, when cancer develops in the vertebral body or grows in the vertebral body and posterior elements, as you can see here, it not only destroys the mechanical property of the vertebrae, but also any minor injury can cause vertebral fractures. With vertebral collapse, the metastasis, the extensive metastatic disease may extrude fragments of tumor into the vertebral canal or just by compressing on it, causing compression of spinal nerves and spinal cord. Last case we'll talk about is osteoporosis. In osteoporosis, there is decrease in the bony element. It is problem in bone quantity, not bone quality. Bone quantity. It's a metabolic bone disorder. It commonly occurs in women in their 50s and 60s and in men in their 70s. There are many factors that influence development of osteoporosis, include genetic predetermination, level of activity, nutritional status, and in particular estrogen levels in women. That's why in women it occurs in their 50s and 60s because the level of estrogen decreases significantly at the age of menopause and after. Now, osteoporosis have typical complications like crush or burst fracture, vertebral body fractures, or distal radius fracture, or hip fractures like femoral neck fracture. That's all for this video lesson. Please, if you like this video, please hit the like button and subscribe to keep me encouraged, and I will keep uploading for you. Thank you.